Hello, everyone. It is so wonderful to have all of you with us today. I'm Lauren Henry, Executive Director of U Chicago Alumni and a proud alumna of the college. The Harper Lectures are one way that we continually support the life of the mind, bringing the university's faculty, research, and groundbreaking ideas to our community around the world. And it is my pleasure to welcome you to the first Harper Lecture of our 2025-2026 season, a discussion about making health more accessible to everyone. I'm thrilled but unsurprised that more than 1,000 members of our community of alumni and friends have signed up to join us today. Our discussion poses a big question. What would it take to give everyone a fair shot at a healthy life? Our moderator and panelists are on the front lines of that work, and it is my pleasure to introduce the faculty who are joining us for this discussion. Dr. Marshall Chin is the Richard Parrillo Family Distinguished Service Professor of Healthcare Ethics. He is a practicing general internist and health services researcher who has dedicated his career to advancing health equity through interventions at the individual, organizational, community, and policy levels. He co-directs the Robert Wood Johnson Foundation's Advancing Health Equity, Leading Care, Payment, and Systems Transformation program. His recent publications include How to Fix a Broken Healthcare System, Pathways to Maximize Health and Well-Being for All, and The Plight of Marginalized Populations in 2025, The Assault on Health Equity Through a Systems Lens. Dr. Chen was elected to the National Academy of Medicine in 2017. Dr. Monica Peak is the Ellen H. Block Professor for Health Justice in the Department of Medicine. She is an internist, bioethicist, and health services researcher. Her research identifies ways to optimize doctor-patient relationships, integrate the medical and social needs of patients, and address the structural inequities that impact health outcomes. She is an associate director for the Chicago Center of Diabetes Translation Research, the executive medical director of Community Health Innovation, the director of research for the McLean Center for Clinical Medical Ethics, a senior associate editor for the journal Health Services Research, and an editorial board member of Diabetes Care. Dr. Peak is also a member of the National Academy of Medicine. Dr. Elizabeth Tung is a social epidemiologist and practicing internist in the section of general internal medicine. Her research focuses on the impact of social conditions on health, with a special interest in race, place, and poverty. She has participated in community-based strategies to improve health on Chicago's South and West Sides, committed to advancing health equity and eradicating disparities. More recently, she has been transforming her epidemiological work into healthcare interventions that advance health equity by addressing social conditions and their consequences. Dr. Tung is currently a principal investigator on two studies funded by the National Institutes of Health, one examining a school-based community health worker program to support family and economic stability as root factors in preventing youth violence. And our moderator today is Dr. Neda Laiteerapong. She is a board-certified general internist who is committed to promoting lifelong health by individualizing the prevention and treatment of chronic physical and mental diseases. Dr. Laiteerapong is a leading researcher of individualized diabetes treatment and is heading up efforts to integrate behavioral healthcare into UChicago's primary care. She is also the Associate Director of the UChicago Center for Chronic Disease Research and Policy, which promotes research and policies that bridge the gaps between medical practice, medical research, and health policy. She also trains medical students and residents on internal medicine in the outpatient and inpatient settings. We will make time for your questions later in our program, but for now, I ask you to please join me in welcoming our panel to the virtual stage.
Hi, everyone. Um, so I'm very, very excited. I'm truly honored to be here today. And as we begin our conversation, I want to do some level setting. There are two words that get thrown around a lot. And so I think it's really important that for you all to follow our conversation. And I hope it's going to be an exciting one. I'm truly excited. Is the two words health equity and equality. So there's lots of really good definitions out there. For health equity, the one we're going to be using today is the one from the Robert Wood Johnson Foundation. And that is that health equity means that everyone has a fair and just opportunity to be as healthy as possible. This contrasts with the concept of equality, which is providing everyone with the same resources, treating everyone just exactly the same. And that does not necessarily lead to what we're looking for, which is fair and just opportunities. Okay, So, with that background, I want to just start off by helping you understand where each of these speakers are, on this panel is coming from. So, I'm going to start off with Dr. Chin. I want you to just tell us a tiny bit about what got you into this type of work and what inspires you to do this work.
Well, thanks, Neda. So, two main reasons. One is family background, that I'm third generation Chinese American. My grandparents came over in the early 20th century. My parents grew up in Boston's Chinatown, big families. And my mom's side was noodles, and my dad's side was laundry. And most of my uncles then on my dad's side worked in the laundries in Chinatown. It was the jobs they could get at that time because of discrimination. And so at a young age, I saw the bamboo ceiling or glass ceiling then. Most of my uncles and aunts were very talented, hardworking people, but there clearly was a limit on what could be done because of discrimination against Asian Americans, Chinese Americans at that time. The second reason is that I think anyone in clinical medicine or healthcare, so a social worker, educator, nurse, a physician, it just takes, 1 week in training before you see the disparities just front and center. One example, I did my fourth year emergency department rotation at San Francisco General Hospital, Cook County Hospital, San Francisco. I remember what looked like an affluent, beautiful young white woman in serious psychic clothes coming in the emergency department with a big gash over her forehead. And everyone hovered over and said, well, don't worry, the plastic surgeons will take care of you. I later took care of myself as a fourth year student. Another white woman who was not a pretty woman, a Russian immigrant, who was crying and had a gash on her face from her boyfriend had beaten her up. And I, the fourth year medical student, was assigned to sew her up. So the disparities are just front and center in many different ways.
That, yeah, I want to ask if Monica has a similar. I don't know what to say, Marshall. That's a powerful story that I haven't heard from you before. Monica, do you have a similar reason or other reasons that bring you to the table?
Yeah, I think a lot of us are motivated by our personal background to work in this area. So, my mother grew up in sort of came of age in racial apartheid in this country. She grew up in the Jim Crow South. My father grew up in Ohio, but was an active student leader in the civil rights movement. And both of them were first generation college graduates. And so, in my household, the um, the commitment to education as a way for freedom for Black Americans was really clear, and the need to be committed to social justice for everyone, particularly Black people, but also other marginalized populations. And so, I did not yet know what my trade was going to be, although I had always talked about being a doctor. But I knew that I was always going to be committed to social justice. And so for me, being able to find a way to blend both of those passions has been just yeah, really rewarding.
That does make a lot of sense. And Liz, I know that you're also from the social epidemiology side. You're also quite interested and got involved in this work. Do you want to tell us more about that?
Yeah, so I grew up in Metro Detroit. So I'm, a daughter of one of the great Midwestern cities that has seen really great urban decline. And so I honestly think that most of us who grew up in the Detroits, the St. Louises, the Clevelands, we kind of grow up with that innate sense of the color line. And color line being what W.E.B. Du Bois described, how he described racial segregation. Um, I've been reflecting on this recently because I have a 5-year-old who just started asking me questions about some of the racial differences that she sees in Chicago. And now being a mom and coming at it from that angle, I'm realizing how plainly kids really do see these things growing up. They just see it clear as day and call it out. And so I'm starting to wonder if, seeing inequity and asking the why is a fairly basic human instinct and something that little kids do all the time. Um, and so it's just something that I've been reflecting on lately and just trying to think about more. But ultimately, as I've aged and had a million other experiences, I feel like for me, it's been all these little things kind of accumulating over many, many years that just continues to reaffirm what I saw when I was a kid, and has kept me asking the why and kept me digging more and more and more over time. So
Yeah, that makes a lot of sense. As we're talking about equity, I want to zoom in on the concept of health equity. And so I want to hear first from Marshall, and then feel free to jump in. You know, when we think about how we're going to improve health equity, that's a lot of your work, Marshall, is sort of thinking about different types of interventions, different levels of interventions that we can do to try to move the needle on health equity. Can you give me just some background as to why that's so important and why we should be thinking carefully about this more so than other forms of equity or just in general?
I'll give a concrete example that as you know, I just came back from clinic this morning, and typically in a half-day clinic, at least 3 of my patients will have diabetes, typical, South Side diabetes population and just prevalence of diabetes. Um, a lot of very preventable complications. And so diabetes can be a devastating illness, but much of the complications are preventable: blindness, amputations, kidney failure, heart attacks, strokes. We're taught like in medical school, well, prescribe insulin, prescribe medications, work on diet, exercise. And I can tell my patients that and have them come back every 3 months. And if I just tell them that and educate, right? Well, oftentimes in 3 months, nothing has changed, right? Because I haven't really delved deeply to find out, well, what is that individual patient's circumstances, the challenges they have, and what solutions will work for that particular patient. And so Monica and I have done a lot of collaborative work at Southside Diabetes Project where we worked on, for example, improving communication between clinicians and patients. And Monica will talk more about this regarding trust and actively involved patients. We work with the clinics, both here in University of Chicago as well as Flight Qualified Health Centers. How do you develop team-based care where the whole team, the doctor, the nurse, the educator, the social worker, together as a team can address the combined medical and social problems of patients? And then we work with the community regarding some of the structural issues. So we partner, for example, with the farmers market south of the Midway on some healthy eating programs, or Save a Lot, a low-cost grocer on the south side, where we did some of the diabetes education tours, where we were taught the patients to read food labels, for example. So the problems are solvable, but we have to address the particular problems of patient communities, which involves partnership with the communities.
That makes sense. I just want to jump a little further into a little bit because you brought up the Southside Diabetes Collaborative. Like Monica, you want to like, did this work? Did it work to partner? Was a healthcare system interested in doing this? Was a community interested in us partnering? And how did that go? And did it help people?
It really did. It was one of the most incredible things that I've done in my career. Patients loved it. Patients really, really loved it. And I remember that I would sometimes, Hyde Park is small, Chicago is small, and I would bump into patients years later, and they would, or their family members, in the grocery store, at the Nike outlet, and they would remind me that they had been in our patient education class, and how well they were still doing, or it really touched people's lives in meaningful ways and their families. And we were able to learn so much about the community and collaboration with community partners. We worked with a number of federally qualified health centers, and that is what it's going to take. Like the disparities are pernicious. They're hard to tackle for a reason, and it's not just one thing that's going to solve the issue. We have to understand all of the different things that are contributing to why we see inequities, and then have to try and figure out how we can address all of the different things that are contributing to those.
Yeah, Monica, why don't you share it's all about the love story.
So, one of the things that I learned over and over again with all of our interventions was that the most important thing was that people felt cared about and loved with our patients, no matter if it was a texting intervention or the patient classes or whatever. The thing that was the most important was not the transportation vouchers or their whatever. It's that people, particularly who feel left out of healthcare systems or left behind, or uncared for, really felt seen and heard and cared for by people in the healthcare system and felt loved. I'm from the South, I'm a hugger, and so we created safe environments where people would come in and be greeted with a hug and, you know, reminded on their birthday that we cared about them. And that social glue, that was the most important thing in their lives to create that kind of social capital that helped them keep coming back to the classes, keep coming back to the things that we were creating in the communities. And that was helping to motivate behavior change.
So it sounds really effective. And I want to think about like, how scalable is that? Right. So I actually wanted to ask Liz about this question because she thinks about the neighborhood and the networks and how and Marshall used a really tough word like wait, who you said pernicious? Like that's a really tough word. And I agree. Like this is a really tough problem we're dealing with. Like so I mean your intervention seems really like a lot of love, a lot of
Mhm.
hand holding, a lot of frequent touches. And I don't know, Liz, what do you think? Is it possible? Can we scale this type of stuff? Marshall as well.
Yeah, I mean, I think that all things are scalable if they become integrated into the way that we practice regular routine healthcare, right? And so, I think a lot of these interventions, when they're brand new and they're innovative, right? But it doesn't have to be innovative. I'm not sure. Maybe this is the way that we should be practicing healthcare in the United States. Um, but when they're brand new, there's kind of a cost threshold that you have to think about. You have to fund things that are new. You have to make sure that things are being implemented the way that they should be implemented. But over time, as it becomes accepted as regular standard of care, I think that it's scalable, as long as we have the kind of political will to to essentially pay for it and implement that into and have kind of a payment model for that, which I know Marshall studies
Yeah.
in depth.
Yeah, I agree with Liz, like the institutionalization, and I think we're going to come back a little bit later, the economics. Ultimately, there has to be a business case for doing things. And there's a great economic, societal business case for reducing inequities in terms of the health of the population, the productivity and economic productivity of the country. So, reducing health inequities saves literally hundreds of millions of dollars per year. The point, though, is that the current healthcare system is not designed intentionally to support and incentivize equity. And so, as Liz says, and we can get into this more later, there are specific reforms that need to be made in how we pay for care to basically support and incentivize equity. Um, in some ways, the Southside Diabetes Project was ahead of its time. That the current fee for service healthcare system that was predominant when we were in the full heyday of the Southside Diabetes Project would not support the health equity interventions in some ways. Now we're in a better situation where there would be more of a chance for institutionalization and sustainability as we start getting to more modern alternative payment models.
Sounds good. And, it's early to talk about money. So I'm going to zoom out a little bit again. You guys are all doctors. I'm a doctor. You're all general internists. You practice in the outpatient setting. You practice also in the inpatient setting. You guys are also teaching medical students and residents and college students. You're inspiring people. You may have inspired some of the people in the audience today to like become doctors or become healthcare, change agents of the world. So I'm going to talk to Dr. Peak about this and feel free to jump in because a lot of her work is thought carefully about the doctor-patient relationship. You have a background in medical ethics. You have a position in Bucksbaum, work there as well. How do you think doctors play a role, both maybe negatively? How do we perpetuate this persnickety problem? How can we also resolve it? What can we do?
It's a really important question. I think that a lot of people assume that because we have good intentions, because we take a Hippocratic oath to do no harm, that we are somehow immune to the biases that everyone else has in the world. you know, that we know as a society that we have biases against, you know, racialized minorities, against, immigrants, against women, against obese people. These things, occur, and we actually can measure them. Everyone can go online and, Google implicit association tests and find out what your own implicit biases are, because we've figured out a way to measure the short and the long neural pathways. And so doctors have them too. We're just regular people. And what we have learned is that those biases, those cognitive shortcuts about people, impact health outcomes in several ways. They impact the relationships that we have with patients. And so patients may be less likely to trust their physicians. So they may be less likely to come back for care. We never see them again, wonder whatever happened to those people until they show up in the emergency room when things are way out of control. Disease is diagnosed way later, or they may be less likely to adhere to the plans of care. I wonder why their blood pressure is so high. They're not taking the medications that you've prescribed. And so there's that, all these consequences of poor relationships. And then there are the actual recommendations. So people that we have biases against, we actually have worse recommendations for care. We're less likely to say, hey, would you like to have that cancer screening? Would you like to have the state-of-the-art treatment for X, Y, and Z? So the kinds of care that we deliver to people is actually different. And so that's where we see the disparities in healthcare delivery. And so there are lots of different mechanisms that occur in healthcare settings, some of which can be attributed to sort of structural factors, institutional factors, but some of them which are directly related to the people, the clinicians who work there, and the kinds of relationships and medical care that we are directly responsible for. But the good news is that we have been working to try and figure out how we can um, address those things. We know that we have biases. How can we be more in tune and aware of them so that we can sort of check ourselves in real time and be empowered to, you know, talk to our colleagues? That seems a little inappropriate. Perhaps we can think about this a different way. And so a lot of the work that our colleagues in general internal medicine do is think about how we can not just observe and measure and document disparities and interpersonal biases, but how can we work on reducing and addressing them?
Riff off one of Monica's points that she emphasized mostly the interpersonal aspect of physicians and others, and she did mention structures. Structures are ultimately people, right? In terms of like people create structures. And so something like the University of Chicago medical system is a structure, and different systems and clinics can be built to either be better tailored to meet the needs of communities and patients or less tailored. And so University of Chicago has really done quite well, I think, over the past decade, 15 years of starting to, for example, do quality improvement with an equity lens, or think about specifically how do we avoid one size fits all approaches and think about then, are we truly serving everyone, and in particular, those with the least amount of power and most marginalized? So one example is that um, there's a data analytics group at the university that creates these algorithms to, for example, help identify patients that might need additional resources. And this is sort of hot now in terms of AI and algorithms. There's a danger of like bias seeping into the algorithms. And the University of Chicago was one of the leaders and one of the first groups to be doing meaningful work of thinking about how can we purposely design algorithms so they aren't biased and so that they do serve everyone from our most affluent patients to our poorest patients and across the different neighborhoods here in Chicago, as one example of like building a system, a structure, an analytical process to specifically try to advance equity.
And I know on the hospital side, Every single quality measure, they very carefully look at how things are different by different types of patient characteristics. And they've been doing that the whole time. And when I talk to other people at other places, they're like, "Oh, Neda, you're a health disparities researcher." I'm like, "No, no, 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 no. Like, you're talking about Marshall, you're talking about Monica, you're talking about Liz, and you just forget when you work here, it's just part of what you do. Like, you don't, like, if you're not interested in that, don't, may not be exactly, at least for healthcare. This, not my section. I'm joking. Liz, Liz, I feel like you had something to add to this conversation about this or anything else.
Specifically about what? All the things that we talked about.
Oh, I was just thinking of the doctor-patient relationship. Kind of the role that we play as clinicians, and I think about the work that you're doing on trying to help people who experience trauma, and what you've been doing to try to help them with legal issues, and what your perception is about how we might be, as doctors, playing a role in either exacerbating or improving or decreasing health equity issues.
Yeah. I mean, I think trauma plays a big role in the doctor-patient relationship. We've recently published a couple of papers, essentially showing how, trauma and especially PTSD symptoms can be associated with hypervigilance and avoidance and, difficulty with trust. And so all of those things really make an impact. And I think physicians have to take on the responsibility of knowing how to address trauma, how to detect it, how to help patients work through it, and then also how to gain their trust despite it, right? And so there's a lot, there's a lot there for sure. And we do have a couple of programs that we're building. One being called Recovery Legal Care, where we offer bedside legal assistance to patients who have been affected by violence and violent injury at our trauma center. And so, essentially we have lawyers going to the bedside offering civil legal aid, which is a form of poverty law. And really, I think one of the biggest things that people get out of that intervention is a feeling like, oh, you actually get the problems that I care about, because the problems that I care about are my housing. The problems that I care about are the fact that I don't have enough money to put food on the table. And so our lawyers being able to address those issues that are so close to the day-to-day lives of patients does a lot. It goes a long way to build that trust and kind of cross some of those bridges in terms of, the impacts of trauma and their consequences. So
that is such a great program, and you're such a good resource for understanding how to make that sort of bridge between the healthcare system and the legal world. That's definitely not an area that most doctors know what to do, and I've certainly reached out to you for individual patient cases where I'm like, oh, this really bad thing happened in the community with the police. What does my patient do about it? So it's really important work. Okay, Marshall, you brought up the topic about money. I gave us like a 10-minute reprieve from talking about money. I know that there's people in the audience from Booth, this illustrious school affiliated with the University of Chicago. So could we just spend more money? Like if we just reallocated resources, there's this concept I do, distributional cost effectiveness analysis. It's a concept that's very popular right now in the health economic world. Can we just redistribute money and give more money to one group, or just get more money and solve our way out of this? Is that all this is?
So there's an estimate that about a quarter of the spending in healthcare in the US is waste. Whether it's administrative waste, like insurance processing and a lot of paperwork, or low value care in terms of unnecessary x-rays and CAT scans and procedures. A quarter, that's a lot of money. And so if that were actually allocated towards useful care that improves health, we do have enough money in the system. The fundamental problem is that the US healthcare system, the incentives are not to maximize population health. What the game is that every large organization is trying to improve their payer mix to get more of the highly reimbursing, privately insured patients trying to avoid caring for the uninsured, trying to avoid caring for lower and reimbursing insurance like Medicaid. So you increase your market share so you can have more negotiating power and boost your rates that come to the center. I mean, that is basically, the game that all the systems play, which just because it's the rules of the game. I mean, why do we have a cancer center hospital being put up, right? Partly because that was the quid pro quo that in exchange for the University of Chicago agreeing to become a trauma center, which they lose money on, the agreement with the state was, well, they will approve then the cancer center hospital where the profit we have there can be then redistributed to something like the trauma center, right? So, imagine if you had a healthcare system that actually rewarded and supported and incentivized things like prevention, like primary care, like addressing medical and social drivers of health. I mean, we'd be a different situation. There's a National Academy report maybe a decade ago that came out with recommended population health metrics for community. So what, for example, if the University of Chicago was responsible and held accountable for the health of the South Side, and we used metrics like high school graduation rates, right? Rates of death from substance abuse, teen pregnancy rates, that type of thing. You see how it takes you in terms of a different sort of pathway of trying to emphasize the holistic view and addressing the medical and social drivers as opposed to, the game of, again, like, let's try to improve our referrals for, cancer care and orthopedic surgery and GI procedures that bring in the money.
Oh, harsh indictment on an institution you've spent 30 years at.
Well, it's not unique to the University of Chicago. This is every place. And I'm not blaming the University of Chicago because in a sense, we're just playing by the rules of the game, right? And, the University of Chicago, we have missions in terms of research and teaching and whatnot. And what they will say is, unless we're profitable, we can't then cross-subsidize the education or the research or whatnot. So again, I'm not indicting the University of Chicago. I'm indicting the U.S. healthcare system, and ultimately, all of us, our public policymakers and the public, in a sense of letting this happen.
The thing is that we are an ecosystem, and healthcare, medical care is really only responsible for about 10 to 15% of health outcomes. And so all of these other things, education, having a job, living in having a safe place to live and lay your head that's not full of, rats and other, germ infesting, organisms and toxins and pollutants that are, you're going to breathe in and cause cancer and other kinds of things. All of these things are much more likely to directly affect your health than, ultimately when you get sick and come to the hospital. And so that's why we think of these social drivers of health as being more important to address in the long term, in the big picture. And if we really want to have healthy communities and think about everyone having an equal chance to live their best lives. And so everyone has to be in the game. And we've just recently, in the past, 10 years, we've seen a marked change in how not only health systems, but other, non-medical systems are starting to think about what skin they're willing to put into this game to move the health needle forward. And so that has been a game changer,
And I'll add a little bit to that too. In terms of what Marshall was saying with trauma centers, for example, being really expensive. I think that the issue is that we have a healthcare financing system where the incentives are misaligned and where doing the right thing is actually extremely difficult, right? What happens when the system that you're working within makes it harder to do the right thing? And what would it look like if we had a healthcare system where you were incentivized for doing the right thing instead of disincentivized and penalized for it, right? And so, opening a trauma center is expensive and it's very difficult for a health system to do. And so then the question is, why is that our healthcare system? And the answer to that is very, very complicated. But I think I like the example of trauma centers because it's a very concrete example of this, of the financial misalignment. And when you do try to do the right thing, a lot of times you financially get penalized for it. And that's why we've seen disproportionate hospital closures and loss of access in places that serve populations that are underinsured. And the reason that we have geographic sorting is because, not only is economic status geographically sorted, insurance status is also geographically sorted. And so the payer mix that Marshall talks about it is really what I call a proverbial payer mix because it's in reality, not the case for a lot of hospitals. A lot of hospitals don't have a good payer mix. They don't have, Cadillac private insurances to offset the public insurance that pays less. And they're very, very dependent on that public safety net. Um, so yeah, there are big, big structural issues. A lot of it kind of stemming from financing.
Yeah, I've been hearing about closures at Sinai Hospital that have been happening in the last couple of weeks. Primary care docs doing great work, refugee clinics closed, and these docs have been committing their lives to, helping some of the most vulnerable people in our communities. Just, their life career just closing because of decisions around funding and, trying to stay solvent as a healthcare system. And you can't blame them. But you're right. Like, I whenever I interview a lot of people, and we talk to lots of people who come through the walls or debating coming to University of Chicago for one reason or another. And I always say to them, like, our healthcare system, it doesn't make sense. We're a private hospital on the south side of Chicago with the largest Medicaid, number of Medicaid patients that go through our hospital in the state of Illinois. Explain that one to me, All right. We've been a little doom and gloom. I want to ask a question that can kind of talk about people who are outside the healthcare system. What can we do? What are the opportunities that exist? What can someone outside the healthcare system do to advance equity in their communities? Are there opportunities? What can people do?
This is an important moral dimension to this, that in some ways underlying everything we've talked about is sort of a vision of what it means to be human and how we care for one another. And a lot of what we're discussing is what actually is happening in the healthcare system is frankly cruel. There's a great essay by Adam Sewer, I believe his name, in the Atlantic from a while ago, New Yorker maybe it was. The cruelty is the point, I think was basically called. How it's a lot of what we're doing nationally, and this is predates the current administration also, it's been cruel, how we sort of treat people and what we accept. So in some ways, it's the American history, right, of the whole neoliberal pull yourself up by the bootstraps, and if you're not doing well, it's your own fault, ethos, as opposed to a more of a communal sense and equity, basically trying to ensure that everyone has a fair and just opportunity for health. So I think for everyone, including the people on the call, part of it is the conversation, of saying this is the kind of society that we believe in, and that we won't stand for elements of cruelty, which include, for example, health inequities. I mean, as a provider, we have no choice, right? We're not going to throw someone out of the emergency department. We're not going to care for them, not care for them, right? So in some ways, this is what I think society overall, probably does believe, but this doesn't reflect in our policies. And then, frankly, people have power as voting citizens, of the candidates and the policies that they support. And ultimately, this does come down, as Monica said, both health and social service policy, and the vision of who we are as a country and how we treat each other.
Okay, so I hear voting. I know you said a bunch of other things, but I heard voting. And speaking our minds. Are there other opportunities?
I mean, so what I was mentioning earlier is that our healthcare system is going to function best when it functions as part of a larger ecosystem. When we recognize that health is a function of lots of different systems that are working together. And so the idea of health in all policies, that the government had, how can, what is housing doing to promote good health? What is the transportation system doing to ensure good health? So many of our patients aren't getting to their medical care because of transportation issues. And a lot of times we see, out on the road, some health centers that provide free transportation will see their little vehicles. Every health center should have that, you know. And what kinds of public transit do cities have? What kinds of walkways and sidewalks to help people just be more healthy? And so again, health in all policies. How are we working together so that we're all moving towards health? And we're all thinking about creating systems that work for the most vulnerable, that work for the most marginalized, and in so doing, they'll work for everyone. And so, and investing in that. And so that is budgets are moral documents. And so thinking about it that way. And ultimately, it's always cheaper to invest in prevention. But we have decided that we'd rather pay the cost of bad outcomes because we be they people in prison or whatever. It's always cheaper to send people to school and college than it is whatever. It's always cheaper
Yeah.
to give people vaccines and primary care than treat them for cancer and put them on dialysis later. Prevention is always cheaper. We've always known this, but we as a society have not made the conscious and moral choice to make those investments because we believe that not everyone deserves it.
I guess one another important point, building upon Monica's last comment, was that it's not a zero-sum game, like the equity. So you hear this argument a lot that, oh, if we're going to give more money to African Americans, well, then whites will not benefit at all. The reality is that like everyone in the whole nation benefits from equitable services. So the visual is like a curb, like like little like cuts and curbs where for people with disabilities that have trouble walking also helps them, a young couple with a rock stroller of a young child, right? And so before I talked about how economically is really the nation's benefit to eliminate health inequities, as well as then like the policies which tend to, as Monica said, address the medical and social are the ones that benefit all folks, including poor white people, frankly. And so a lot of the policies then that lead to, again, the more holistic viewpoint are ones that benefit everyone. So everyone gains.
Mm, great. Well, I want to thank you guys. This was a wonderful discussion, as I'm not surprised. I want to transition to some of our questions from the audience. And there's a lot of really good ones. So apologize to anyone in the audience who does not get their question asked, but we'll do our best.
Which would be almost everyone, because
well, so here's a question. We've talked about national and we've talked about local, and let's talk about Illinois. Okay, so this is a question from Allison. What can we be doing in terms of legislation and policy to address health equity at the state level here in Illinois? Are there any obvious targets that you think we can undertake that would move the needle here?
So one avenue that we were really looking into before all the talk about Medicaid cuts was Medicaid waivers. And so, there was a lot of effort and momentum behind this idea that we would be able to fund a lot of the social interventions. So, for example, funding bedside legal assistance for patients affected by violent trauma. We were looking at Medicaid waivers as a way to kind of fund those clinical encounters with a lawyer. Obviously, a lot of that stuff is up in the air right now, which I will say, I don't necessarily want to open the Medicaid can of worms, but $900 billion in cuts to Medicaid is the thing that I think keeps a lot of us up at night right now. Because it really, truly, truly, truly is bonkers. And I worry that most of America does not understand how bonkers it is if it were to actually happen. But but I think Medicaid waivers were a good kind of policy point. And I think maybe in the future they can continue to be so.
Yeah, I agree with Liz, and it sort of ties into what Monica's point about like the holistic health and all policies that address the medical and social in a holistic way make a lot of sense. Another way, for example, is that with our Robert Wood Johnson Foundation program, one of our grantees was the Illinois team, which included some of the Cook County area folks, the short-term hospital folks and whatnot. And they had a program where they were working with people with housing insecurity, homelessness, because those folks tend to be expensive. They, not surprisingly, they will bounce back to the emergency department or hospitals, costing a lot more money. So they found cost-effective ways to basically create combined housing, care coordination systems, keep people out of the hospital. Which then the next part would be then like working with the Medicaid agencies and all with these waivers that allow more flexible use of the funds because it saves money over time and improves health. So innovation is possible. It's a great example of like addressing the root causes in a flexible way, and you align the payment systems so that you're rewarded for doing the right thing and you have a business case for doing the right thing.
Right.
Okay. This is, I'm glad you guys opened the insurance can of worms. I didn't have to. There's a question from Akbar. If you had a magic wand, what a fun part of this type of job, you can have a magic wand. You could wave at an insurance company and fundamentally change their structure. What would you change? And he's asking this, or I assume he's asking this, Akbar, because he's had discussions with colleagues about why insurance companies won't cover long-term interventions like healthy food subsidies. So what would you do to a health insurance company if you were in charge of it and had a very long time horizon to wait for the benefits to accrue? So like healthcare for all or insurance for all.
Yeah, that's one of the challenges is that because insurance companies know that people change so frequently, they don't want to fund long-term things because the benefit will probably accrue to a different company. Um, so they want to invest in something, where they can see the benefit right away. And so it is closed units where we can really see people being willing to do the investments so that where the investment in primary care happens, you save money from prevented hospitalizations. But, unless the hospital is attached to that same unit and the savings can be seen, it's all one place, then as primary care, hey, hospital, give me that money back, so like it has to be an integrated systems where the payments, and so um, the same thing is true for insurance companies. And so thinking about how their financing and what they're paying for is going to be something that they're going to, see the benefits of. And so, you know, there are ways that they've been thinking about doing what's like shared savings plans with providers and health systems. And so I think that um, there are things that have been on the table that have been feasible, and we've seen. So Marshall and I had we oversaw a project that was sort of the next phase after the Southside Diabetes Project, which is essentially looking at projects like ours across the country, and one of them was in Maryland. So Marshall, do you want to talk about that one?
Um, I'll talk about part of it, and you add the other part that in some ways the trend, Neda, is to basically think about starting to integrate payment more closely with the care that's actually delivered. And I'll talk about the Maryland state policy. Maryland's a very interesting state because they have a so-called all-payer total cost of care system. All payer meaning every payer, Blue Cross Blue Shield, private insurance, Medicaid, Medicare, they all pay the same rate. So there's not an incentive basically to avoid Medicaid patients, right? Because it's all the same rate. They have a total cost of care system, meaning that a big system like University of Chicago, we will be responsible for both the health as well as the cost of care of like the South Side Chicago. We would be given a set budget. And then, if we come under budget, we profit. We come over budget, we lose money. So all of a sudden, there becomes a big incentive on prevention, primary care, keeping people healthy and out of the hospital, as opposed to racking up the dollars by, providing a lot of procedures and surgeries and high tech care. So that's an example of policies that align the incentives. I think you're going to go for a different part. Maybe we can talk a little bit about, I guess, what maybe it's a little clinical or like Western Maryland in terms of, yeah.
Yeah, no. That's all I was going to say. And so they did just tons of investment in their community health workers and outreach and basically going out, looking, no stone was left unturned to find people where they were at and bring them into healthcare had they not been, to do community-based education, to do all the preventive stuff that that ultimately saves money. And they were one of the hospitals that was able to stay afloat because they took that strategy compared to a lot of other hospitals that closed.
Maryland sounds very special. I never thought about moving to Maryland, but it definitely has a different philosophy on who's responsible for health, which is pretty exciting. I mean, the next question is going to take it down to the patient level, and you're kind of starting to talk about this with, helping navigate the healthcare system a little bit and the complexity there. This is a question from Robert, and he says, one of the most important factors in healthcare outcomes, especially in serious cases, is whether the patient has an advocate, a family member or a friend who can help them navigate all the roadblocks. And of course, this affects patients with smaller social networks compared to larger and social inequities and things. Are there ways that we can help educate potential advocates on how to help patients navigate the University of Chicago? I'm joking. They didn't say that.
It's the way you do, Monica. Go for it.
So, yes, I mean, I would say that there are lots of avenues to do this. We have official people whose job it is to be patient navigates, navigators for the system. There are people who are community health workers who work in healthcare settings and community settings, and sometimes in both spaces. We can do a lot for patients who have chronic diseases to educate them. I spent a fair bit of my time doing that. That's part of what I study and really am invested in having patients and their loved ones be more empowered when they're talking to physicians, when they're trying to navigate the healthcare system, to sort of realize all of their rights and to have more say in what happens to their bodies in their healthcare encounter. But that also means that the health system and the clinicians and providers that take care of them have to be willing to cede some of our power and to educate patients and communities about the rules, and like, this is the system in which you're working or coming and being a part of, and let us show you who and what we are, so you can find your way around. That is part of our responsibility. Part of that is making sure that we talk in a way that is understandable to everybody, that we're not talking in jargon, that our literacy level, our health literacy level is like we're just talking to regular people like I am right now, and not trying to jargon it up and confuse people. So there are a lot of things that we have to work on as a health system to make it more accessible and more empowering to patients and their advocates. And I think healthcare has a long way to go in that, but it is certainly has for a long time been part of what we consider to be the chronic care model, as having activated patients at its core. And so, yes, it's something that I think a lot of internists strongly believe in.
That's wonderful. We have just time for one tiny question. It's a big question, but I'm hoping for a tiny answer so we can squeeze it in. And this is from Jenny. This all seems a little overwhelming. We're talking about battling social, political, institutional forces. Is there anything that we could do? Smaller, tangible, day-to-day things that we can do as citizens in our worlds that can improve the overall health for patients and people and just reduce disparities. So you only get like 30, like one sentence, 2 sentences max each. It's a tough one.
Advocate for yourself as well as your friends and families in their medical care. look at the neighborhood things, like Monica said, in terms of them like healthy walking areas, biking, healthy environments, healthy food choices, and then the macro policy. I mean, we all have power as people who vote. And then this is the overall discussion of the kinds of society we want to be, of caring for one another, that we are not a cruel society.
Thank you, Marshall. Excellent. Come on, Liz, go.
So I'll just say that we have never been in a time in our country where the effects of our policies, our federal policies, have a negative impact on the health of the most marginalized populations. So if you're interested in improving health equity, then vote differently.
Yeah. Yeah, I mean, I echo what Marshall and Monica are saying. And yeah, I mean, ultimately, I think that my biggest concern is just that with the current political landscape and the current policy landscape, things are going to get a whole lot worse if we don't do something now. And so I think that there really is a call for political action here. And unfortunately, like that is the most urgent call, I would say. I think that there is a lot of innovation and a lot of stuff on the horizon that we're excited about and can really impact things in the future, but all of that is under threat right now. And it's a very scary time. And so I think that it's not a very hopeful message to end on. So maybe I'll let Marshall interject some more.
Well, that's
But
an arching point that, the University of Chicago, a very intellectual place, there's a very strong evidence base for all the things we've been talking about over the course of the day. And the University of Chicago is also a place of the life of the mind, where things like free speech, like democracy, the ability for truth to prevail, are principles of the University of Chicago. So I think there are all those overarching points, which are core University of Chicago, are embedded in our recommendations regarding what everyone can do to advance health equity.
Well, thank you, everyone. That was a very provocative and I hope informative conversation. I learned a lot. I want to go ahead and invite Lauren Henry back to help close us out.
Thank you so much. I want to say thank you to our panelists for such a thoughtful discussion. I might ask all of you in the virtual audience to please join me in thanking Doctors Chen, Peek, Tung, and Laiteerapong. And I want to thank all of you for your insightful questions in keeping with exactly what I would expect from a University of Chicago audience. We saw more than 50 questions come in. I am really, truly proud to be a member of this community every day, but I think it is never more, and I am never more proud than when I have opportunities like the one we've had for the past hour, learning about the university's work in addressing complex societal challenges. So I hope that this has inspired you to remain engaged, whether that's you attend another event, you volunteer, you provide philanthropic support for faculty and students, you just talk about what you learned today, the groundbreaking research and thought leadership that's happening at the university. You can learn about all of those opportunities and more on our Alumni and Friends website, which is alumniandfriends.uchicago.edu. But most importantly, thank you again for joining us. We look forward to seeing you at future programming, and I hope you enjoy the rest of your day.